Hello everyone, I'm Ramli Sahara, Content Executive for Healthcare Excellence Through Technology. And welcome to this webinar, Delivering the Healthcare of the Future Today, Building a Stronger Nursing Workforce with Virtual Wards in partnership with Current Health. This is part of the series of HEC22 webinars supporting the healthcare community to navigate our evolving healthcare landscape. We have a fantastic panel lineup today, chaired by Natasha Phillips, Chief Nursing Information Officer at NHS England. Thank you everyone for taking the time out to join us today. Our speakers will be answering questions at the end of this discussion. Please add any and all questions you have into the Q&A function. There's also an opportunity to vote up questions you like, and we will get to as many as possible. Now, without further ado, I'm going to hand over to Natasha. Thank you, Natasha.
Thank you, Ramali. I'm afraid, Ramali, that I can't turn my camera on because it says you have control. Right, there we go. It's working now. Brilliant. Thank you very much. So, yes, welcome everyone. I'm really thrilled to be chairing this panel of expert clinicians who are leading the way with virtual wards. Virtual wards are a really great step forward in terms of allowing patients to get the care they need at home safely and conveniently rather than being in hospital. And I was really privileged to go and see this in action at Norfolk and Norwich, and we have some of the nursing team from there with us today, and I will introduce those to you shortly. But it's really great to have a panel of clinical experts who have real on the ground experience of how we do this and are really valuable for learning from as we think about how we scale up in line with our NHS ambitions to really scale up the use of virtual wards across the system. So today is really a chance to listen, converse, learn from others' experiences. My job today as chair is going to be to try and hold that space and make sure we get the most of our time together. And without further ado, I'm going to introduce the real experts here who are going to share their experiences with you as we go through this hour-long conversation. So firstly, we have Claire Beard, who's the virtual ward manager at the Norfolk and Norwich Hospital, and her background's in ICU and as an anticoagulation CNS. And then we have Mike Waters, her colleague, and he's the operational lead, also a nurse at NNU. And then after that, we have Karen Downs, who's our clinical lead from the virtual ward hub at, it's such a mouthful, Wrightington, Wigan and Leigh Teaching Hospitals. So great to have you here, Karen. And then lastly, the non-nurse in the room, but a really important member of the panel and also a clinician is Dr. Matt Wiltz, who's the Associate Director of Clinical Affairs at Current Health. So I'm going to kick us off by asking, in the first instance, I'll go to Claire and then to Karen to say, tell us a bit about the virtual wards that you're running in your areas.
Hello, my name's Claire. I'm the virtual ward manager here at the Norfolk and Norwich. Basically, we cover everything. We started in February 2020 in the height of the big second wave, started off with COVID patients, weaning their oxygen and monitoring them at home. It quickly became apparent that there was a lot more that could be done here in Norfolk and Norwich. So we have built ourselves out to 40 virtual beds. So we're staffed for 40 virtual beds using Current Health kit, and we cover medical, surgical, emergency, women's. The only thing we don't cover in the hospital at the moment is children's, but hopefully we're going to have that coming. We are a 24/7 service, so our patients can get hold of us any time of day or night, and we are very much based on a physical ward. So anything that we can tap into on a physical ward, we can also tap into on our virtual ward. So things like dietitians, specialist nurses in anticoagulation, or in diabetes, oxygen nurses, that they all have access to our Current Health and can tap into us at any time. We're still working on therapies, so physio and OT are sort of next to come to do virtual. But that's us really in a nutshell.
Thank you, Claire. And I wonder if I could bring your colleague Mike in at this point to sort of tell us a bit more about that sounded very familiar to me as a nurse. It sounded very much like any ward that I've ever worked on. But what's different about this model of care, Mike?
I think the difference is it's very personalised method of care. So, when you're on a ward working as a nurse, you've got lots of different things going on. You can't concentrate on one patient at a time. The value of a virtual ward, in my eyes, is that you can have that one-to-one interaction with the patient. So using the technology, which we'll go on to later on, we can have face-to-face conversations with our patient at least once a day. And you are literally just concentrating on that one patient. You're not getting interruptions from other nurses, from other patients on the ward. So you get one-to-one time, which is really valuable. We've found we've discovered a lot more about the patient than we would do normally. They're willing to answer more personal questions. We find out a lot more about their conditions, and it's really, really helped us. And the outcomes of, again, we'll talk about this later, but the outcomes have been so much better. I found it really beneficial, and I know I should say this, but I'm really passionate about it. It's the future. It's the way we've got to go. The idea of bringing vulnerable people into a building that's full of infection is just such an old-fashioned idea, and we've got to get around that and do things differently. And this is one way of doing things differently, I think, that really works from all perspectives, from patients, from staff, trust point of view. It works all ways, and I can't see anything wrong with it. It's got to be the way forward.
Thank you, Mike. And I'm just going to call out to our audience who are with us today. Do put your questions in the Q&A. At the end of our session, we've budgeted some time to really come to your questions. But what I'm going to do is try and sort of ask some of the questions that I suspect you might want to know that you would ask yourselves. And I'm going to go on to Karen to tell us a bit more about the model that she's running, and whether any of that resonates and anything different that you'd like to add, really.
Absolute resonates. So I'm Karen Downs. I'm the clinical lead for the virtual hub at Wrightington, Wigan and Leigh. And the virtual hub was born out of oximetry at home that then lent itself to monitoring at home, which is kind of sits in line with the NHS at home tiered monitoring model. And then we're evolving now, if you like, into the virtual ward model. We've got virtual wards up and running since February this year. We've just hit over saved bed days of 1,000, which is fantastic. But just like Michael alluded to, it's the benefits for the patients, absolutely, for both benefits for the patients and staff, that really are resonating within our trust. We are in GM, Greater Manchester, the smallest bed base trust. So it's part of our trust strategy to get that care closer to home in our strategies 2030. So we're very much bought in from an exec level of they saw the future of this, they saw the direction that we were moving in, and very much wanted to align with what was going in what is now ICS. We've managed to get 3 virtual wards up and running. So our acute respiratory ward, cardiology is building, but we started off with like a general medical ward, virtual ward, sorry, just with the ability of a very low criteria, referral criteria, very low exclusion criteria, and keeping the criteria for onboarding quite open, so we knew what type of patients that we could onboard using our wraparound care and community. It's a unique, because our community is linked in, is part of our, bigger trust, wider trust. It enables us to pendulum, if you like, where the pressure is needed from acute and into community, working with our partners in primary care.
Thank you, Karen. So I'm trying to build up an image of what sort of patients do you have? It sounds like it, you as you said, you've got a very low exclusion criteria. So what would the average patient on your virtual ward look like?
Anything and everything. We have team leaders who are band 7s, experts in their field, all with acute background. Will go and assess the patients alongside the full MDT, so our full therapies ACTS team, to ensure that medically the right patients. So any patients that are just requiring trajectory monitoring, so they've come in, been admitted, had an assessment, they've got a primary diagnosis that they're receiving a treatment care plan for, and all that is required is trajectory monitoring of that patient with possible community diagnostics. Them are the patients that we can onboard. What could stop them is obviously functionality. So are they able to go home and function and be able to look after themselves, or look after themselves with some wraparound care that we can instill in an urgent sense, because we all know that there's a great deal of pressure on our social care services out there. But using engagement and using the digital platform, what that has enabled us to do is look at the ways we're all working, not just the virtual hub, but using digitalised care in that we can provide more care to the many. So it's been tremendous.
And I noticed from your biography, you said this is an approach you're taking with the at the ICS level. So I'm really curious to imagine this connection. We know as nurses our sort of unique role is joining up care, isn't it?
Yeah.
And it's often a challenge in terms of sharing information to get that joined up approach. So how does the sort of intersection between you guys in the hub and community nurses, for instance, work?
So we're very close. We work very closely. We're a community service divisionally, but we're very much in both acute and community. We feed back to both divisions and work with nurses and teams in both divisions. And I think that's enabled us to rise our profile internally faster than we thought we predicted, and get some buy-in, that clinical buy-in on board, and create that positive noise. Our vision is that we will work in networks. So in locality, in GM, it's proposed that we have 4 networks, and working in them networks will enable us to share that resources, share expertise, but pool that expertise centrally by having a Greater Manchester approach to the virtual hospitals. I mean, when I met with my partner trust, which was Bolton NHS Trust, it's the fact that when our patients have to move trusts because of bed pressures, it's often a block to get them patients back because of acute bed availability. And this just provides another resource, if you like, to get the patients where the patients want to be at the home.
That sounds fantastic. And I'm going to sort of shift gears, talking about that, where patients want to be and how they want to be cared for. Let's shift gear into sort of, firstly, the sort of patient experience of this. And then I'm really curious about the nurse's experience of delivering care in this way. For me, when I hear that, I think, well, this is what I signed up for. Sounds great. Can I have a job, please? But let's find out a bit more about your nurse's experience. But first, I'm going to go back to Claire before asking you to come on to that a bit, Karen, and say, so what are you hearing from patients? What are they saying about their experience of this model of care? Claire, would you be able to give us some insights into that, please?
Yeah, absolutely. So patients, particularly in the last couple of years, they have been really frightened to come into hospital and come into the hospital environment because of, you know, the pressures that we've been under, the fact that they can't see their relatives, that they're stuck in a hospital bay with the fear of catching COVID or knowing that COVID is in the building. It's quite frightening for them. So if we can get them home into their preferred environment, it makes a huge difference to lots of people. We've had people that have come through us that just need to get back into their own home, and they're much more settled in their own home as well. And it's lots and lots of different reasons. It's things like deconditioning of patients. We know that when they come into hospital, particularly in COVID times, they were kind of stuck in their bed bay. They couldn't wander around the hospital. They couldn't wander around. So the deconditioning, the eating and drinking, as nice as we try and make hospital food, it's not what you would eat at home. It's not at the times that you would eat at home. So there's so many benefits of being at home. If you want a cup of tea, you can just go and make it. You don't have to wait for somebody to come around with a tea trolley. We've had patients, one of the patients that always sticks out in my mind was one of the first patients that I put on. We work with our home link team that are our sort of boots on the ground. So they will go out and do IV antibiotics or things like that for us, and they'll do dressings and they'll do phlebotomy. So if we need anything of that for our patients, they will do that. We had a gentleman with dementia who needed 6 weeks of IV antibiotics for osteomyelitis. So NNUH at Home, or our HomeLink company, were able to go out and do that for him. Now, he had a very good setup with his wife at home. She was his main carer. She was very keen to get him home. So we were able to get him home. And when I saw her on the ward before they went home, she said to me, he's just getting worse. And in her mind, it was just progression of his dementia, progression of the disease. When we got him home, about 2 days later, I spoke to her again, because we video call all our patients every day. And I spoke to her, and she said, do you know what, you've given me my husband back. And I said, what do you mean? And she said, well, I thought he was getting worse. But actually, getting him back into his own environment, where he knew where the toilet was, where he could get himself a drink, where he could do all of those things, it wasn't a disease progression, it was just confusion, because he didn't know where anything was. So getting him home, it made a huge, huge difference to her. And we've had that with a lot of patients, particularly the more vulnerable patients. We've had lots of patients with learning disabilities that have gone back into their environment, their natural, their getting people back to where they want to be is huge for the patients. And like I said, taking away that fear of the hospital environment. We've had one gentleman who every time we video called him, he wasn't home. And he would literally see the missed call and call us straight away and say, sorry, I was out on the backfield with my dogs, because his dogs were his life. And he was really very, very anxious about his dogs being cared for by his wife, because she didn't walk them for the same sort of length of time, and she didn't train them, and she didn't do, you know, they were gun dogs, and he could do his gun dog training with them. So patients find it hugely beneficial, particularly those patients that have been in hospital for a very long time and have become almost institutionalized. You know, we had somebody that went through the worst COVID experience you could possibly think of. He had all of that kind of thing, and then he eventually went home. But him and his wife were very, very anxious about it. And just knowing that for the first week of being at home, somebody was there, somebody was keeping an eye on him, we were monitoring his oxygen levels, it just gives them that reassurance, because it can be very scary. So yeah, from a patient, they absolutely love it.
That's brilliant here. Thank you, Claire. And I do wonder, and I can see questions in the chat about it as well, but two sort of things about one, sort of digital exclusion, and maybe I'll come back to Karen on this one. Have you come across people who can't access this because of the tech, or a nervousness about the tech, and how do you overcome that? And secondly, you know, some people are quite nervous about being at home, you know, being lonely or unable to cope. Have you come across those patients, and how do you manage that, Karen?
So we learned very quickly that we needed to flex our service model and provide that digital at-home support. So we've actually now advertised for band 3 support, healthcare support, digital support workers, but up to now, that's been provided by our nurses and assistant practitioners that go in the home and support. We've up to now, out of 144 patients, we've had one patient that we absolutely had to just change the way what we was doing for him. We could not get him engaged in the digital platform. However, we got him doing his own observations and write it on paper. And we just left the video with him because he could work the video. He liked that. He just didn't like the strap that was on. So there's ways of this. It's just working with your patients and their carers to know what's best. And it's that initial assessment. The assessments are there for inclusion. They're not to exclude patients. We go above and beyond to ensure that we can make this as equitable and inclusive as possible to all our patients. As an inpatient, we are only just, we've got going really on our step down model from hospital, but what we're keen to do is tap into that step up model so that they don't even have to come into hospital. and they can get that secondary care if needed on the virtual ward and get teams involved, the expert teams of secondary care involved whilst on the virtual ward, using the digital dashboards, board rounds, and obviously the video connectivity to the patient that can give them that one-to-one consultation.
And I don't think that's so different to nursing generally, is it, in terms of individualized and working with the person you have and with what you have. It sounds very familiar, but what are you hearing from nurses about their experience of working in this sort of way with a virtual ward approach?
So being a frontline nurse myself, and still very much on that clinical floor, we all know what the struggles and strains are. Even in community, you hear of nurses afraid to give eye contact, to engage in conversation because of the workload and the amount of the patients that they need to review. What the difference on here is exactly what Michael said earlier. The nurses feel like they can actually have that communication, and the communication is so much greater because of confidentiality. It's a one-to-one. It's not a one-to-one with curtains around and 20 other people in the room. So you, unfortunately, but fortunately, you do find out a lot more, and there's a lot more to act. So what our nursing team team of AHPs as well say is that they're almost future-proofing health. They're putting things in place and referring to that supportive teams after that virtual ward episode. So it feels like that they're plugging the gap between acute and primary care, if you like. So it's a bit more supportive discharge with them future plans in place, particularly around frailty, using the geriatric comprehensive assessment. We're hoping that carries through what starts in the acute or in community, carries straight through and with them, and it's a continuous assessment highlighting them deterioration in frailty early, so that we can get teams in, helicopter teams in, as we keep saying, and dealing with that early deterioration to stop it or slow it down.
Thank you. And that leads me on to thinking really about the technology. So Mike, how important is technology in this care model?
I think, well, in the care model we use at the Norfolk and Norwich, it is the vital ingredient, really. I've sort of jotting down a couple of the questions in the chat that I could sort of go through. I see that Matt's answered a few of them, but we obviously decided right from the start to go with Current Health, which gives us feedback every 3 minutes on heart rate, pulse, etc., etc. But the most important part is the communication part as well. So there is a button on there to call the patient. The patient can call us at any time.
Oh, we've lost sound. I think we might have lost Mike's sound at the moment. So I'm going to come back to Claire and see if she could help us with that question.
Sorry, I just ran out to go and tell him to come off mute. He's in the next room.
Are you back, Mike?
Are you back, Mike? No.
So how important is tech, Claire? How does tech help you?
The tech is basically the bones of what we do. Without the tech, we wouldn't be able to send these patients home safely and be able to keep an eye on their obs every 3 minutes. So the wearable on the arm gives us heart rate, oxygen levels, respiratory rate, skin temperature, and movement. So we can encourage the patients to sort of do all of that. We can also add in BP cuffs, which most of our patients do go home with, and scales and spirometry. So we've got all of that data coming through for the patients all of the time. The main thing that the patients find comforting is the fact that they go home with a tablet, which we FaceTime them on or video call them on at least once a day. The tablet is two-way communication though, so there's a button on there that says, I need help. when they press I need help, it gives them 3 different options. One of the options is that they've got problems with the tech, so they can go straight through to Current Health, who will troubleshoot that for them, or they can text. They have a message from my care team, so they can send us a message, which again, we have the ability, or Current Health has the ability to have 2-way text messages with the patients. And the third one is, I need something, I need to speak to somebody now, or I don't feel very well. They press that. I always tell my patients it's exactly the same as pressing their call bell in a hospital. Although having said that, I think we tend to respond a little bit quicker sometimes than the call bells, but it will give us an audible alert, and it will outline the patient in red on our screen, saying that that patient needs something. Because we're 24/7, they press that button at 3 o'clock in the morning. Within 5 minutes, there's a nurse calling them, saying, what's wrong? What can we do? How can we help? Do we need to pull you back into hospital? Do we need to get a medical review? Do we need to change your medication? Because our patients are inpatients on all of our systems, we can pull them back in very quickly. Our tech is very important for the patients, and it's important because it's 2-way. So it gives us the information, but it also gives them the reassurance that we are there, and they can get hold of us whenever they need to.
Thank you.
Just checking, can you hear me now?
Yeah,
we can, Mike. Is there anything
brilliant.
you'd like to add?
No, I was saying it's quite the important part of technology from my point of view. I don't know if Claire covered it because I was busy trying to sort my audio out, but is that the amount of observations that we're getting through. So every 3 minutes, the observations upload, so we can quickly see a deteriorating patient much quicker than you would in hospital. I always think if you're on a hospital ward and you're doing obs every 6 hours, you're not getting that same information. So we can quickly. I was just talking to the rapid response team today. They're really interested in using our gear because it's so much quicker to spot a deteriorating patient. So hopefully we can stop them first before they deteriorate too far and put something in place. So, you know, I think a lot of people are concerned about, well, actually they're at home. So what happens if something happens at home? I'm confident that we would catch that patient before anything major happened. We're obviously going to get the odd ones that you can't do anything about anyway, whether they're in hospital, whether they're in home. But I'd like to think that with the technology that we've got and that we're using, we can spot a deteriorating patient quicker.
And are there some patients you can't access because of the digital platform? So, for instance, they don't have broadband coverage.
So we with Current Health, they provide their own router using mobile technology, and it's using any mobile provider. So as long as you can pick up a mobile signal, you can use the technology. We've got ways of getting around it if there is any issues. Norfolk's not the best for broadband. So ask for telephone.
Oh, you've gone again. Oh, what a shame.
I'll pick up, but yeah, Norfolk is notorious for not having great signal, as you see. But we've had patients that live in sort of very remote areas who have no problems with the kit, and no problems with getting signal from them. Sometimes, very rare occasions, if they are very, very rural, we'll get slight patchy. The obs will come through a little bit patchy, but again, they don't have that. They wouldn't have that level of monitoring on a ward anyway. So if we get obs through sort of, you know, every hour or so, that's more than they would be getting on a physical ward. But yeah, we don't have any issues with the kit, and setting it up is so easy for the patients. You know, we've had sort of elderly patients that don't have any issues with the kit at all. I had a 94-year-old that needed to come to us, and she was saying, well, I'm not going to be able to do it. I'm not going to be able to do it. And I said, okay, let's just try and let's see how you get on. And I said, and then when we were talking through things, I asked for her next of kin's telephone number. So she picked up her iPhone, flipped through it, found the phone number for me. And you just think, well, if you can do that, and I just said to her, if you can do that, you can use our kit. And she said, well, I've got an iPad. And I said, well, then you can definitely use our kit because it's easier than all of that. All they have to do is turn the tablet on and it tells them exactly what to do. And most people have got somebody at home that will help them with the kit anyway, you know, sort of family or friends or next door neighbours or whatever. But it's very intuitive, much more than a lot of kit.
Thanks, Claire. What I'm loving about this this time we're spending together as well is I have got an eye on the chat, and it's amazing to see everybody sharing and, you know, saying, have you got a SOP on this or that? And it's really great to see the chat along the side and see people helping each other out. And we will try and cover off all the questions that are coming out, but I think you're all answering each other's questions, which is quite helpful as well. I'm going to come back to you, Karen, and ask you a question about, I saw in the chat earlier someone asking about, so with such a broad spectrum of patients and this new way of working, you know, what does the nurse that delivers this care look like? What knowledge and skills do they need? How do we prepare them? So how are you preparing nurses for this role?
I think because we went to acute medicine, that tends to be what's attracted people into the roles that are in. Definitely as a team leader, you need that experience and knowledge and skills to deal with deterioration, recognise, and I did want to come in about the technology, because it's not all about your pure observations that creating used to. We all know before physiological changes, they're them soft signs that you can detect, and what the digital provider helps us to do is build surveys, so build assessment tools around that, say for pain, into the program of care for the patient. So it's like a prompt, so you get that information through alongside your physical observations as well. But as we're moving to that step up model, we realise that maybe, you know, there is a bit of a gap in our service provision, in that it's that community knowledge and how to manage patients in the community. They're a nifty bunch, our community nurses. Innovative, they have to think on the feet. The things that they come up with to keep patients at home is truly inspiring, and it's what's inspired our team to think outside their box, if you like, of being able to work around patients and use the wraparound services to keep them safe at home and monitored and deliver that care.
Thank you very much. And as you were talking, it prompted me to think about how are you using all this information? You talked about reports. So how are you using the information to know that you're having an impact?
So we get the data feedback. So current health providers feed about compliance with using the equipment. We get feedback from the surveys that we've created with current health, but also we monitor the impacts, just using at the moment a simple data sheet, but working very closely with our clinical informatics team. They're building our EPR virtual ward to be able to lift that information out, so we can look at length of stay, patients that have needed escalation, in hours, out of hours, maybe transfer or referrals to other experts. So we have a respiratory ward, but we might be asking for some cardiology input if a patient's deteriorating, or the frailty team input, and what does that look like? So we're working with our behind clinical informatics team to build our virtual wards alongside us as we grow and evolve.
How exciting. I mean, that is one of the really interesting and opportunities, isn't it, to have so much information about it, that you can really start to look at anything, like you say, from efficiency with length of stay all the way through to safety, in terms of looking at deterioration and how quickly we respond. So
in particular, we've used the 4-app tool. It's a really good tool at detecting delirium, and what's stark at the minute, but we're small numbers, so this would be really good to get out some national opinions on it. That the prevalence of delirium in hospital we're not seeing on the virtual wards, despite patients having had or be at risk of delirium. So that, and using the tools and being able to compare the two of inpatient hospital and a patient on virtual wards at home is really interesting, and it just paves the way really for future. What can we improve on, and builds our evidence for acute care at home.
That's fascinating, isn't it? And I think you're right, the national data will be really interesting. And of course, we have the virtual ward SITREP, national SITREP, that looks at sort of capacity, flow and usage. But it will be great if we could start to think about expanding that to look at some of the outcomes from this as well. And I know that's something I speak quite a lot with Ming Tang and team about. I'm really keen that we start to get to that understanding sort of the impact. But when you have digital data, the opportunity is obviously there to do that. And what I was quite interested in the chat, Emily from NNUH, Emily Wells, had an article accepted in the British Journal of Nursing, which is fantastic. So the other way we learn is obviously sharing, and as a researcher, the sort of academic literature is always dear to my heart. So I think I should ask the NNU team, is there any other ways that you're using data and information to inform how your virtual wards are evolving?
So yeah, so we have joined up with our Power BI colleagues, and we have a virtual ward dashboard. So much similar to what Karen, I think, is starting to go with. So we list down length of stay already. We do bed days saved, so we can monitor how many. Can you hear me, by the way?
Yes, yeah,
I'm not chatting to myself again. That's right.
No.
Bed days saved, length of stay, who's referring, so we can keep an eye on which specialities we need to focus on if we can get more referrals from. Exactly like that. Patient satisfaction survey. So our patient satisfaction survey, I think, is currently sitting at, just looking behind, 98.7%, which is absolutely superb. Lots of different things. There's lots of different things in the pipeline as well as to what we can do and how we can use this data to take the virtual ward forward even further.
Thank you. And one of the concerns that I often hear, or the challenges we face, particularly as a nursing profession, knowing the national nursing shortfall we have, is how are we going to staff these things? And so I'm curious about how you're attracting nurses and the impact in terms of what does this mean for nurse retention? Are we draining other areas of care in order to support this model? And how might we tackle that? Big questions. Sorry to put you on the spot.
No, that's fine. So when we first started on the virtual ward, set up our virtual ward, we were using shielding staff. So that's how we done it first. So there were staff that we were not pulling off acute wards. They were at home wanting work to do. And that's how we started it off. And a lot of them have stayed with us. In fact, the majority have stayed with us. Now we also involve nurses that can otherwise not be working physically on the ward. So we've got nurses that are awaiting operations on their wrists, on their hands, that can't do the physical work, they've got bad backs, so we're utilising the staff that would otherwise be sitting at home, wasting their expertise, basically, and we're tapping into them and using them. And the other thing we're looking at doing is sort of recently retired nurses who are interested in helping out. It's a really good way of using that expertise and involving someone that can't otherwise work. So a lot of long-term sick nurses, if they're wanting to work, we can use them on the virtual ward. There is sort of certain points where we have to tap in, and we do have to take nurses from other areas, of course, but that's also evened up by the fact that, as now, we've saved 10,000 acute bed days. So actually we'll reduce it. The long-term plan is we'll reduce the workload on the wards. So that sort of evens itself out. But going forward, we're using nurses that would otherwise not be working.
Fantastic, thank you. And I'm also thinking about advice. I imagine we're in this phase. This is a model that there is an ambition to grow in the NHS. It's likely to grow. So that's fine for now, moving forward. How will we attract nurses, and what advice would we give to nurses who are considering working in this way? Actually, with this specialism, I suppose you would call it, Karen. What's your view on that?
You certainly need time spent with patient. You need that grounding and consolidation time as a trained nurse or AHP in dealing with patients, and having them people skills, picking up on cues. So it's all them essential skills that you gain by doing face-to-face contact with patients. But certainly we found we were very much like, so I have to put it out there, Norwich, so Michael, Claire and Emily were fantastic when we very first embarked on this, and we've modelled ourselves very much on what they were doing because they'd proved the concept of the art of impossible. And we attracted them retiree nurses that was retiring and coming back, or coming to the end of their career, was burnt out and wanted a change. And what we're seeing now is that it's attracting them nurses that have been in, or AHPs that have been in practice 3-4 years and want to be surrounded by that expertise and learn a new knowledge and new trade and deliver care in a different way. And it's almost that cohort of original staffing that we had are attracting the nurses themselves because of who they are and what they know. So yeah, we've been a success at that.
That's fantastic. And I'm gonna bring Matt in at this stage, if that's okay with you, Matt, and just ask, as our resident doctor here amongst a panel of nurses, what do you see in this model that's maybe different for the MDT? What's the opportunities here for MDT working across the system?
Thanks, Natasha. Hi, everyone. Sorry, like fingers of fury typing in the text. If any questions don't get answered, by the way, there, I'm happy to answer in the Q&A or after by email. I also apologize for losing my voice. So for the MDT, I think the advantage of virtual care is that it allows straightforward integration of different specialties, whether people are at home or in the hospital. I think what's important, though, is that everyone from the MDT is on board with the process. I think one of the things that's been kind of alluded to in this is workflow. And what we have to do is take the existing workflows of not just nurses, but also doctors and allied healthcare professionals and put them together on a common pathway for virtual care patients. A pathway that includes analysis of outcomes. And the idea of this is that everybody there understands how patients are being assessed, when, how they're being escalated, to whom, and whether or not the system's working. And if you can do all of those things, then that helps bring the MDT on board, and they can take advantage of the sort of easy and obvious advantages of having readily accessible vital signs and ease of access to the patient.
Thank you very much. And before we move into taking some of those specifics in the chat that you've been valiantly fielding, I think what would be really nice to hear at this moment is moving to sort of implementation. I'm thinking about setting up a virtual ward. Karen, I heard from you that actually learning from NNUH was one of the things that was really helpful for you. I'm going to come to each panel member and say, so if you had one piece of advice for a team about to embark on virtual ward, what would it be? And I shall kick off with Michael.
I knew you were going to say that because I hadn't prepared an answer. So
I can come back to you.
No, that's fine. I think it's consultation and communication. So we found right from the start, it's a new concept, and we know in the NHS we don't like change. So it's all about advertising what you can do, advertising how safe you are, and advertising that you have got the governance in place. So for me, it's getting that grounding first of all, get the basics in place, get the governance in place, then go out and advertise. That would be my main part of advice.
Thank you. And Karen, what's your advice?
Data is king. It will open your doors. It will make people sit up and listen. But in order to get that data, you just need to be brave. Find your key person that is your door opener within your trust. If you can align it to any trust strategies, you've got to buy in with the executive and your trust board. But do a pilot, just see it, see how it works, gain that clinical trust by using people that you know and know you, and show that it can work, even as small as it can. A few patients will. That's all I needed. A 2-week pilot turned into just, well, we're at 5 months now.
Wow. And you're growing in specialties and looking at that as an ICS approach, isn't it? So start small, and work with the willing is what I heard. I'm wondering, Claire, what you have. I can't see you on my screen. What would be your advice? Oh, here you are.
I would say don't say no to anything, and think outside the box, because we've had a lot of people saying, well, I think this might be a potential, but we're not sure. Just go and review every patient that is a possibility, and we've found solutions that, you know, just talking to other people, keeping communication up and thinking outside the box. We've had some really sort of innovative ideas, and it's just keep going at it, and communication with all different specialities and everybody else in the teams. Communication is key, I think. And definitely thinking outside the box and coming up with some great ideas. We have one sort of overarching SOP that deals with all of our patients, and then all of our different pathways come off of that. And we have just the pathways have developed slowly. Start with one key pathway, whether it's your respiratory patients, or start slowly, start with one, and it suddenly becomes a bit of a snowball, and it just keeps getting bigger and bigger, and do it, just do it.
Thank you. And lastly, Matt, before I go to questions from the audience, what would your one piece of advice be?
You know, I would actually echo everything that's been said. I thought when I joined a tech company, it would be all about the tech, but the hard part is the implementation. So I think having a champion is essential, starting small and then growing from there. So don't bite off more than you can chew until you've worked out what works and what doesn't. Being very clear about the fact that there's going to be a little increase in workflow, and hold everyone's hands with that while they get through the hard part of implementation, but then enabling people to understand that the virtual wards provide ward level care, and they're only going to be called in if they're needed. And I think if you can communicate all of that and find someone to champion your tech, then you go really far.
Thank you. So some really helpful tips there. And I'm going to come up to the questions in the chat. So I've seen a number of questions around staffing models. So I'm not going to pick out any particular question, but I'm going to invite the panel to speak about how do you establish a safe, appropriate staffing model for this new way of working. How have you gone about it? So I guess if we ask Karen your approach, and then maybe come on to Michael or Claire to talk about the NNUH approach, because I think what we're seeing is, depending on what you're doing, there might be different approaches in different areas. And so while there's some national guidance on nursing staffing broadly, I know that the national team are looking to think about how do we support local development of guidance, and then learn from that in order to build some principles. So Karen, first, how have you gone about it, and what were the principles?
So as a locality, we do things a little bit differently to our GM partners, and probably nationally, because we were predominantly the oximetry at home team, but we had a service model of intensive, active and passive patients, all needing a degree of monitoring. So essentially, your intensive patients are virtual ward patients. And for 12 months, we'd been timing the interventions that on patients of actual one-to-one interventions via telephone call, the admin side of it, the escalation side of it. And then we've put that, a very good gentleman in CCG put that all in a data sheet that enables us to populate what our caseload is on a day-to-day basis, put our staffing in, and then we know what capacity that we have, and what staffing, if we're well staffed. So because we've still got them services going for oximetry at home and monitoring at home, as well as the virtual ward, it's a bit of a complicated staffing model. But we provided that information to GM, and they've provided a staffing model for our locality. an ideal model, which tends to look at ACP-led management band 7, and then your band 6s coordinating with band 5s underneath and band 4s. But particular phased, we do 12-hour shifts at the minute, but they feel there's a greater benefit in phased shifts over the day to cover an 8 in the morning till 10 in the evening service.
And ratios, Michael, how have you gone about ratios? Is there any science to this?
Well, the science we did the background work was obviously we started from nothing, having no data, so we were on the first to start it. So we sort of like developed our own ratios through our experience, and we're continually reassessing these things. So we set up, we've got our patient nurse ratio. All of our patients on the ward are saving an acute bed, so they're acute hospital patients with digitally enabled tech. So we're starting from a different grounding, so we know the acuity of our patients. So currently our model is that we have if we're over 20 patients, we have 2 trained nurses on a day shift, 1 trained nurse on a night shift, and then we've got a model for, as we increase our bed state, how the staffing goes up. I'm more than happy to share that with anyone who wants it. So you can look into it, and we've done that mainly through looking at the data as we've evolved from the start, and it's been a bit of trial and error, but that's how we've looking at the evaluation and everything, that's how we've found the best way to do it and the best way of working. And it's continually evolving because it is a new system, so it's a new thing. We're looking to go into the safer staffing model as well, so we can do our own templates and do acuity fixing and that sort of thing. That's something again for the future, but it's sort of like evolved with us, to be in all honesty. Yeah, and I've seen the chat. I'm more than happy, Kerry, to share it with you.
Brilliant. And I also noticed in the chat some community colleagues and others and asking about work moving out or a knock-on impact in terms of their workload and how they manage it. And I guess there's also an implication in terms of spotting and increasing referrals for others. So you staff the virtual ward, but ultimately that has the potential to generate more work where others have to pick it up. How are you seeing that? How do you manage that?
So from our perspective, we don't really use a lot of community staff. So we decided to contract our work to an NUH at home, HomeLink. So they do all our IVs and our blood taking and that sort of thing. So that's part of our business model, is that we've actually outsourced that work. So we don't use a lot of community nurses. Going forward, that might well change, because as we go into more admission avoidance, then that might happen, and we are going to need to use more community staffing. But currently, all our community work is done on a contracted basis with a company.
Thank you. And Karen, is anything different from your neck of the woods?
Which is why we went into a more tiered service offer, so that we can look at what we can lift and shift, if you like, workload into the hub on the lower grade of monitoring from different, say, heart failure, district nursing, hospital at home, picking them patients up that may just require a telephone call or a follow-up call, and monitoring in between, so that we can alleviate their capacity, if you like, so they can take some of this work on. But it is something that's continually highlighted, especially to network level, that it's not just about funding the virtual wards, it's about funding our supporting wraparound services as well, as community diagnostics need to up their game.
Thank you. And I'm struck by a question that's come up about the name virtual wards. So it's become part of our vernacular now, hasn't it? And yet, in reality, I suspect it might mean different things to different people. But this person's asking, have you had any feedback in regards to how patients and carers feel about it, with an idea that perhaps they might not like that the term itself is off-putting? What does the panel think? And do you think there is an alternative title that we should be giving this? Does virtual wards describe what's in the tin?
I'll start with that one if that's all right. Sorry.
Thank you. Go for it, Mike. I saw Karen shake her head, so I'll definitely come back to you, Karen, but Mike, go for it.
This has been something that's brought up to me before, and I've never really thought about it or seen a problem with it, but thinking about it, what does virtual actually mean? Does it mean that the ward doesn't exist? Does it, so I think there is a case for looking at actually what is it called? Because like you say, virtual means so many different things to different people. And I know that's something that's been brought up in our community teams as to whether or not it should be called a virtual ward. I don't have any answers to what it should be called, I have to say. But yes, that has been mentioned as something we are thinking about.
Great, thank you. And Karen, what do you think?
It's bothered me because nothing about it is virtual. It's just simply delivering care at home differently. I really wanted to call ourselves Hospital at Home, but that service already existed. So there's something about asking ourselves, what is that Hospital at Home model look like? And is this just an extension that needs to be included in it? I did put it out. I did a trust members and public presentation, and I did ask them about the term virtual and what it meant to them, and they had absolutely no issues with it. But I suppose it's my issue then.
Yeah, well, it's interesting, isn't it? And worth paying attention to, and probably worth asking service users what they think. Someone in the chat has suggested care at home. When you said hospital at home, Karen, it did remind me that actually the principle is we're trying to move the public away from this idea that everything has to happen in a hospital. So what really is it, is it just great care at home? I don't know, but it's a really interesting one to think about. So answers on a postcard, and I'll leave it to you running services to give it some thought, really.
Well, I'm with Karen on that one as well, to a certain extent, in that actually there is a time between hospital at home and virtual wards anyway. So should we be looking to merge together and produce something that way? But that's for the future. But yes.
And we're almost out of time. Something that I wanted to draw attention to everyone's attention to was if you want to know more and access some really great resources and advice, the team that run this out of NHS England have got a great website where there's lots of resource, and I know that people like Karen and Mike, you and Claire and your team have contributed to stuff that sits there. So nhs.uk/virtual-wards would be a great place to visit after we've completed this webinar. And I think the best way to wrap up now is to just give each panel member the chance to have their last word on where they see the future of virtual wards, or whatever we choose to call it. So I'm going to give Claire an opportunity to answer first.
Thanks. Wasn't expecting this one, so now I need to think. I do think that we are going to end up with virtual hospitals, or whatever we call these hospitals, but I think that everything that can be done in a physical hospital, or there will be a sort of a mirror in a virtual hospital, and I think we'll have a step up and a step down model. At the moment, we step down from our acute hospital, but it would be nice to sort of do a bit more of the admission avoidance and the long-term condition care, and shift that model to a very fluid model of step up, step down. You get cared for in the community, but you have that link with the hospital as well, so that you can move, and there's a bit of fluidity in that. When that'll happen, I don't know.
Well, I have to say, given that I put you on the spot, Claire, I think that was a brilliant answer. So step up, step down, joined up, seamless fluidity. I like the sound of your future. Karen, what do you think? A similar answer? Anything different to add?
It's similar. It's just that we see it as the front end of any admission to requiring acute care, and the back end of early supportive discharge, and that future proofing, that being forward thinking about what is next for our patients and what might they need in future, and providing it.
Brilliant, thank you. Michael.
Yeah, again, I can only echo what the other two said. I think my vision and our vision here is that we have a virtual hospital, and that spreads across anywhere. It doesn't have to stick to regions. It can stick nationally. It can go anywhere. That's the joy of having a virtual ward. You know, it has to be a seamless between the community and the acute hospital, primary and secondary care. We have to have a seamless fix in there. We all have to work together and bring it all together. And we're at a fantastic opportunity to be able to do that, because we're all starting up. We're all new. So let's get it right from the start and all work seamlessly together.
Wow, thank you. And Matt, do you have a view? What do you think's next?
I would just echo what everybody said, and Michael in particular, that there is an enormous opportunity now. Like, there is money there, the tech is there, there's the public will there, and there's the will within the health service. We just collectively have to make sure we do it right. And I think webinars like this and the expert panel you've had on here is a great way to spread those learnings. And yeah, something I'm extremely excited to be a part of.
Thank you. So it's interesting, isn't it? I think we've had a really rich conversation, unpacked some of the challenges, which undoubtedly there are, lots to work through, but the ingenuity of healthcare professionals never ceases to amaze me, and amazing how far we've come so quickly, and so much rich learning between us, that that future, you know, looks entirely possible with a lot of hard work. And what I'm really proud of from this webinar is my own profession, really, in terms of how much, and I've seen it here today, and I see it out on my visits, but nurses, really ingenious, great leadership, working through challenges, and with a real passion and commitment to do this. And what I'm hearing increasingly is that it resonates with the role of the nurse in terms of joining up care and supporting person-centered, holistic care for individual people. So it's a real opportunity, and it's great to see the profession grabbing it by the horns and doing something with it. But important, I think, that with that leadership comes the responsibility of making sure we get things like the workforce modelling right, and so on. And it's reassuring to see people really thinking through those challenges critically, and trying to ensure that everything is safe all of the time, and that people are having a good experience doing this. So curious to see where we go. Great to see the vision for the future from you guys. Look forward to the next time we all get together and have this discussion and see how much further you've got. So thank you everyone on the panel. Thank you for everyone who joined, who made this the rich conversation that it is by putting all those questions in the chat. Do go to that website that I mentioned. There was something in the chat about how people make sure they access all the things that were referenced in this chat. So I'm going to come back to the coordination team. Romali or perhaps Matt can answer, how can people make sure they get a full download and can revisit the content from this session today? Romali, are you able to help us?
We'll circulate that after in a follow-up email. Thank you, Tasha. Sorry. Yes, thank you everyone for asking. We'll make sure that in the post webinar email we include all the links that have been mentioned here. So thank you very much.
Brilliant. And we're 3 minutes over. So thank you everyone, and have a lovely rest of your day, whatever you are doing. Goodbye.